Hello from Trinidad and Tobago and the Caribbean Vascular and Vein Clinic. As we all know, traditional treatment of varicose veins involves and includes saphenofemoral, saphenopopliteal ligation, stripping, phlebectomy, and perforator ligation. And we are all aware of the complications of such procedures, which include the complications of general anesthesia, bleeding, groin infections, cellulitis and abscess formation, nerve injury, which particularly applies to procedures on the short saphenous vein, arterial injury, especially with redo groin dissections, and scarring. These traditional treatments have been, and I dare to say, by and large, replaced by endovascular techniques. This can be likened to fixing the vessels or pipes from within as opposed to traditional surgery where we fix from outside. Endovenous techniques can be subclassified into thermal tumescent (TT) or non-thermal non-tumescent (NT). As the name implies, tumescence is deployed around the vein to be ablated, and this acts as a heat sink and protects surrounding tissue, as well as compresses the vein around the catheter. The heat is generated either by radiofrequency or laser. Here is a quick video on endovenous laser ablation. Note here the laser fiber is placed 2 centimeters from the saphenofemoral junction. More recently, using radial fibers, laser crossectomy is performed in which a radial laser fiber is placed 0.5 centimeters from the saphenofemoral junction. Studies have shown that there is a low rate of thermal damage to the deep veins, that is E-hits, and recurrence from the accessory GSV and ascending branches of the GSV is reduced. One advantage is that when treating truncal veins such as the GSV or short saphenous vein, the very same laser fiber used can be used to treat pathologic perforators. Here we have used thermal imaging to identify a lateral vein and significant but unusual perforator. This was confirmed on ultrasonography and treated at the same time using a laser fiber. How does endovenous laser ablation work? The chromophore theory and specificity to certain wavelengths is now being challenged, and it is thought that at higher wavelengths there is a more efficient transfer of heat to the vein wall, leading to less chance of perforation and therefore reduced pain and bruising. For the proponents of radiofrequency ablation, heat generated by the catheter leads to damage of the vein wall, with followed collagen synthesis and eventual fibrotic sealing. This slide depicts this. Not to be outdone, the radiofrequency manufacturers have devised a new catheter which has an active 0.5 centimeter tip that can be used for obliteration of pathologic perforators. Now let's look at non-thermal, non-tumescent techniques. Non-thermal, non-tumescent techniques involve chemical techniques, primarily ultrasound-guided foam sclerotherapy and the use of glues. Mechanical-chemical involve, for example, clarivane and phlebograph catheters. Ultrasound-guided foam sclerotherapy is relatively easy to use and can be used to inject almost any varicose vein. including around the wound itself, using the technique called terminal interruption of refluxing source or TERS. There are, however, some questions about the long-term efficacy of this treatment. With Clarivane, a disposable rotating angle catheter scores the inner lining of the vein wall, while sclerosant is concomitantly injected. Of course, with such techniques and all the non-thermal, non-tumescent techniques on a whole, there is little chance of damaging nearby nerves. This is particularly useful for the short saphenous vein and the sural nerve. So is endovenous ablation really state of the art? Let's look at this in more detail. So I pose to you, what factors do we look at when determining if something is state of the art? One, we look at closure rates, we look at recurrence rates and reintervention rates, we look at cost factors, complication rates, and most importantly, patient acceptability and changes in their quality of life and PROM studies. And there exists out there a myriad of papers that demonstrate that endovenous ablation is by no doubt state of the art. For example, this paper confirms that endovenous laser ablation provides an excellent alternative to conventional surgery. Again, another big series demonstrates the success rate with both endovenous laser ablation, radiofrequency ablation, and less so ultrasound guided foam sclerotherapy. Another large meta-analysis demonstrated the efficacy in terms of long-term occlusion rates of the GSV when looking at both radiofrequency ablation and laser ablation. More recently is this large series which states clearly that both surgery and endothermal ablation are effective treatments for varicose veins at 10 years, with durable improvement in quality of life and a very low rate of disease progression. However, endothermal ablation was associated with superior clinical and quality of life outcomes. Let's take a deep dive and look at venous ulcers. You may remember back in the day, venous ulcers were first treated with compression therapy, followed by conventional surgery. Open surgery was considered contraindicated, at least in heavily bioburden wounds, due to the risk of surgical site infections. This is particularly true for groin incisions, a region that is already prone to infection. The outcomes we look for after endovenous ablation include primary, which is the time to ulcer healing or the rate of ulcer healing, and secondary measures including recurrence rates, ulcer-free times, and patient-reported quality of life. In Trinidad back in 2010, we decided that because endovenous ablation is minimally invasive and theoretically complication rates, including infective complication rates in particular, would be minimal, we actively treated patients with venous ulcers with early venous ablation, and we found excellent results at 1 year follow-up with no infective complications. In the international forefront, if we look at the ISCHA study, surgical correction of superficial venous reflux reduces 12-month ulcer recurrence. Most patients with chronic venous ulcers will benefit from additional or simple venous surgery, meaning endovenous ablation. This is quite an interesting randomized trial, and the conclusion of this was early endovenous ablation of superficial venous reflux resulted in faster healing of venous leg ulcers and more time free from ulcers than deferred endovenous ablation. again further supporting early intervention in venous disease with this minimally invasive technique. Let's look at the guidelines. If we did this from the start, there would be no need for this presentation. The guidelines clearly state that endovenous ablation is the way to go when treating venous disease. There are a few caveats to this, and I do suggest that you read the 2023 guidelines. So, if there is any doubt in the audience about endovenous techniques being state of the art, let's ask AI. And this is quite interesting using ChatGPT, in which we ask, what is state of the art for varicose vein treatment? And clearly, here comes the answer. Endovenous laser ablation, number 1. Radiofrequency ablation, number 2. Venous seal techniques, sclerotherapy, mechanical chemical ablation. So, is venous ablation state of the art? Yes. Will venous ablation always remain state of the art? Well, probably not. We have recently new technologies being developed at quite a rapid rate, but they are still in the early stages of analysis and study. Thank you for watching the presentation. And should you have any questions, please do not hesitate to contact me at my email posted on this slide.